All right, let's dive right in. Today we're talking about the single most common abdominal surgical emergency in the world, acute appendicitis. Now, if you're in medicine, you know this isn't just another diagnosis. It's practically a clinical rite of passage.
Just think about that number for a second. 1 in 15. That means you are absolutely 100% guaranteed to see this time and time again. So knowing how to manage it inside and out, yeah, that's not optional.
You know, for the longest time, we're talking over 100 years, the playbook was simple. Diagnosis, appendicitis. Treatment, appendectomy. That was it. It was just dogma. Simple, direct, no questions asked.
But things have gotten a lot more nuanced, right? And our approach to this classic problem has too. So the big question we're tackling today is this: is the scalpel really the one and only answer anymore?
So here's our game plan. We're going to start with the single most important question you have to ask. Then we'll walk through the two big pathways, uncomplicated and complicated cases. After that, we'll touch on some special situations and wrap it all up with the key clinical pearls you can take to the wards.
Okay, so this is it. This is the fork in the road. Everything, and I mean everything, in modern appendicitis management flows from this one critical distinction. Are we looking at a simple, straightforward case, or has this thing ruptured? That first call dictates the entire plan.
And here are those two paths side by side. About 80% of the time, it's uncomplicated. That just means localized inflammation, no rupture. The other 20%, well, that's complicated. That means it's perforated and you might be dealing with a phlegmon, which is basically a walled-off inflammatory mass, or a full-blown abscess, which is a pocket of pus.
So let's talk about that big 80% chunk, the uncomplicated cases. This is where we're now facing a choice that honestly didn't even exist a couple of decades ago. Do we go straight to surgery, or do we try an antibiotics-first approach? This table really breaks down the conversation you're going to have with your patient. Look, surgery is the definitive one-and-done cure. Antibiotics, on the other hand, have a really high initial success rate, around 90%, and people get back to their lives faster. But there's a trade-off. They have to accept the risk that it could come back, and a tiny risk of missing a tumor.
And this is the heart of that trade-off conversation. The risk of it coming back. I mean, within 1 year, up to 40% of patients will have another attack. And that risk stays pretty high even out to 5 years. That is a huge piece of information every patient has to understand to make their choice.
And this quote just nails the huge shift in thinking. It used to be, the doctor says you need surgery. Now it's a real conversation. Our job is to lay out those options we just saw, explain the pros and cons, and then help the patient decide what makes the most sense for them.
Okay, let's switch gears to that other 20%, the complicated, perforated cases. Here, things get a little more high stakes, and your decisions about timing become absolutely crucial.
So for a patient who's stable but has a walled-off perforation, the modern play is not to rush them into the operating room. Nope, the goal is to cool things down first. We use IV antibiotics, and if there's an abscess bigger than 3 centimeters, we get it drained. This controls the infection and lets all that angry inflammation settle down, which makes a future surgery way, way safer.
And that brings us to this key term, the interval appendectomy. This isn't an emergency operation. It's a planned, scheduled surgery that happens weeks later, once that initial fire has been completely put out.
And this is the question every single trainee should be asking themselves. The patient is better, they've gone home, they feel great, so why would we bring them back for an operation? It sounds a little weird, but the reason is incredibly important, and it's not just about preventing another bout of appendicitis.
Here's why. And this number is a showstopper. For patients over 40 who had a perforated appendix, the rate of finding an underlying cancer in that appendix when you take it out is a staggering 10 to 29%. Let that sink in. That's why we go back. The interval appendectomy is a cancer ruling out procedure.
Now, of course, this isn't a one-size-fits-all algorithm. We've got to quickly talk about a couple of high-risk groups, older adults and anyone who is immunocompromised.
In these folks, their body's alarm systems often turn down. They might not mount a big fever or a high white count. Their pain might be vague. And because their symptoms are so atypical, the diagnosis gets delayed. And what happens with delayed diagnosis? A much higher rate of perforation. For all those reasons, plus the cancer risk in older patients, we tend to lean much more heavily toward immediate surgery.
Okay, that was a lot. So let's boil all of this down into a few essential takeaways, the clinical pearls you can stick in your back pocket.
This really is the whole decision tree. Step 1, uncomplicated or complicated. If it's uncomplicated, you have a conversation. Antibiotics versus surgery. If it's complicated, your first job is to stabilize the patient. And the critical reminder, if that complicated case is in a patient over 40, that interval appendectomy is an absolute must to rule out a tumor.
And so we end on this thought. For 100 years, surgery was the only option. Now, it's just one of several. And as we get more and more data on non-operative treatment, you have to wonder, are we heading towards a future where, for a lot of patients, the scalpel becomes the backup plan instead of the default? It's something to think about. Thanks for joining me.